Welcome to the office.
Welcome back, Stephen.
Thank you.
It's been a few weeks?
Yeah, quite
What,
a few.
3 weeks, 4 weeks?
3 or 4, yeah.
Yeah. And you came for a few things? The
Yeah.
back, the breathing, the septum, the jaw.
Yes.
How are we doing with everything right now? And this is a good example. This is a follow-up video, right? He's coming in for his tune-ups now, right?
Yes.
And the reason why you're coming in for your tune-ups from NorCal is you're not local, so we're kind of just spacing things out and trying to figure out your balance point, right?
Yeah.
Okay. And let's talk about the jaw and the breathing first.
So the jaw's good, but I still get a little bit of clicks on, I think a little bit on both sides.
Pain though?
Not really pain, no.
Just a little click.
Yeah, just a little click, maybe a little bit of like, a little stuck sometimes, but it still moves, you know?
How's the breathing? How's the shortness of breath?
Shortness of breath, it's getting better, but I think the C3, I'm working on it, but it's still getting a little
But better from last
Oh,
visit.
yeah.
Meaning you are able to breathe deeper. Yeah, there you go. Nice.
Yep.
Now let's see from the diaphragm though. So he's getting there. He's not there just yet. I want you to not move your chest and just push your tummy out before your chest goes up. Push it out, stop, exhale. Breathe in, push it out, stop, exhale. That's his spot for right now. Push it out, exhale. I want you to practice from there. So once you go past there, you're lifting your chest.
I remember I was doing that
Right?
last time.
So now I want you to do it by yourself, please, without lifting your chest. See where you're... So the whole purpose of diaphragm breathing is this, guys, is, well, there's a couple reasons, but in his case is to help him relax more, breathe from the stomach, not raising the chest. It's expanding and opening the lungs to get in deeper breaths. And the control of that diaphragm neurologically comes from the phrenic nerve, 3, 4, and 5. 3, 4, 5 keeps the diaphragm alive.
Yes, sir.
How's the walking? How's the feet? They're still straight?
Feet's good. I think the hip's coming back a little bit.
Okay.
Just a tiny bit.
All right.
But yeah, I've been going on walks a lot, getting out in the sun. It's been good.
All right.
The other thing is, I think you can see it on the X-ray, but there's a little bit of a kind of tightness right here, up here. And I think last time you did a T5, and that worked really well.
Oh, they're between the shoulder blades.
Yeah.
Okay.
Yeah, up here. I think you can kind of see it, but when I move this way, it feels a little tight right here.
Okay. We'll take a look at everything.
Okay.
Cool.
Yeah, but that's about it.
All right. You ready to get started?
Yeah, I'm ready.
All right, cool. So we talked about Stephen's pelvis, and this was a special case. Have a seat, Stephen, or stand, whatever you prefer. And we talked about this. So it showed up as a rotated sacrum on the left with a PIEX. However, on examination, we found that the left hip was moving. It was the right. We labeled both, but if this is a PIEX, this is an ASIN, which means it's gone up and in. And I explained my thought process in previous video why we chose that. Number one was it was the stuck joint. Number two, we have a straightening of the spine, right? And a lot of times when we have a straightening of the spine, usually it's coming from an ASIN ilium, which causes the ilium goes forward and the sacrum comes back, causes that straight poker type spine. That's why we chose that. And if we look at it, we can actually see through the joint a lot nicer there. And we can see it's a little jaggedy and there's scar tissue in there. It's actually binding right at that little spot right there. Okay? So, just a little recap for us. Let's get started. Oh, you got your farmer tan today. I like it. Got that Fresno farmer tan.
Yes, sir.
Yes, sir. You been working? Reading?
Reading, yes.
Starting at the base. Listen to the patient. C3, 10 points. That didn't break, but let's see if there's something hiding out. Oh. Correction. we're going up top. T5, T6, T5, left side. Oh, what are we doing here, guys? And for our new viewers, because I just realized we have a lot of new viewers that have not watched our old videos. So the first question is, what is this thing he's running down people's backs? And guys, this is a mini thermography unit. We're measuring inflammation or the heat from the inflammation. And it's telling us kind of where to focus our exams. It's called a mini thermography unit, nervoscope. It's basically thermography. Nice. Right SI joint, T5, C3, C1 on the right. All right. Head down, sir. Round your back. You drove down, you said, right?
Yeah.
Was it a decent drive?
It was good, yeah.
Nice. One, two, three, four. Actually down at 6. Now let's take a look at this right pelvis. It does look like it started to come out a tiny bit. Back slowly towards me. Top of the joint. Now, if we're going based on the chapters for motion and static palpation, we're feeling for edema, swelling, point tenderness all along the SI joints here. And then when we're looking at the motion, we're moving top of the joint. Does it move? Middle of the joint is where it's getting tight. Bottom of the joint, not moving as well as the top. ASIN will cause the fixation on the bottom and the swelling and irritation. Left side, that's moving. A little tight, but moving. Let's test out both hips. Feet together, open and close the knees. Feet touching, open and close. Good. Left side only. So when he does the left, the whole right shifts for show. Right side only. Right side is more tight from the muscle there. So we're going to continue on, okay? T6, right ASIN. Sit back for me, please. Testing out the neck still. 7, 6, 5, 4, 3. Head down. 3, yes. And 1. Let's check the jaw. Slowly open. Open, open. It is doing better. We're going to test it out after that atlas. Close. I don't know. Let's formulate a game plan, Stephen.
Yeah, because you said it's all connected.
It is also.
So could it be the jaw and the atlas, one of them?
Atlas. I'm going to go with atlas first, right? So I would always work, and the philosophy is from above down, inside out. So if I'm choosing, is it the chicken or the egg? I'm going to say we're going to go with spine first. And we'll see if that changes that right TMJ. If there's any change in the TMJ with the atlas, I'm not touching the TMJ. Okay?
Okay.
Fair enough? You ready for me?
I'm ready.
Let's do this. Let's start with the neck. So we're on third cervical, C2, C3. It's a bifid, so we're going to be on the inferior lateral, posterior inferior lateral aspect. Tuck that chin. Now C3 is the smallest bone in the spine to adjust. It's probably the hardest too. And you got to get right underneath there, and I'm holding it firm right there. Now, I'm going to lose him if I don't tuck that chin. Give me the chin. Give me the chin. Just let it go. Let it go. Good. Good. There it is. There you go. Look up. It's tight. Drop it down, 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 down. Oh. Oof. Nice. Now, let's go right hand up against her. And down. Let's do the atlas now. Let's see. Relax the jaw. Steven! Feet straight, please. All the way. Drop that right ear down, down. Clonk.
That's a good one.
Walk it up, please. Deep breathing as you're walking, sir. Face down on the gray table here. I just had a lady left from Fresno just now before you. I told you I got a bunch of people coming from there, right?
Yeah, you mentioned you had some more.
About 5, 6 of you guys now.
Really?
Yeah, really.
Nice.
No joke. I got invited up there to go see the zoo.
Oh, the Chappie Zoo?
Is that what it is?
Yeah. It's a good one.
So they got a giraffe there that I'm supposed to go feed.
Really?
And they're gonna let me palpate the giraffe's neck. You know the giraffe has the same number of bones, right? Same. They have 7 cervical bones. 6.
Yeah, that's crazy. That sounds fun.
You're pushing. Drop the 2 shoulders down. Damn. Darn it! You're making me work too much. There you go. A little more. Relax. Slide down a tiny bit. Slide your chest. There you go. There you go. ASIN. Walk 2, 3 times, Steve. Good.
Yeah, it doesn't feel as stiff in there now. I like that.
Let's go right side down and do that hip. So, again, we're doing an ASIN, involves slide down. And I know when people watch these adjustments, it all kind of looks the same, but it's not. You know, it's the contact is different, the line of drive is different, the torque is different, the thrust is different, the amount of pressure you're putting, and it's different for everybody every visit. You know, and straighten out the bottom leg, slide forward.
Yeah, not just like sacrum versus pelvis, but like which part of the pelvis, like the ASI?
Is it, I mean, it can be AS, it can be ASIN, it can be IN, it can be PI, it can be PIEX, it can be PIIN, it can be EX, it can be IN. Good test question. How many listings in the pelvis, guys? And then there is the special listing of where both get stuck, and it's called an INEX or an EXIN. Straighten out. Maybe I'll have my bag put a short because we have a couple. I have, I think, 1 video or 2 videos, old videos that show the double adjustment. Now for him, we're going to be here. So here's the PSIS right here. We're going to be right down there. We're setting it as an ASIN, so we want to torque it down and out. And I'm going to roll him towards me. Let it roll, let it roll. Head down, let everything come down. There you go. Nice. Walk it off, please. Good times. Walk it off. Bringing the ASIN down and out. We're going down and out. Now I want you to go face down. And we get a tiny bit more. So let's see if there's any more. I'm on his right glute. I'm right there, sir. Holding the left, pushing down on the right. A little more. That's okay there, boss?
Yeah.
Okay. Tiny bit on the sacrum. That's it. Walk it off, sir. Good stuff. Good. Have a seat back over here, please. The walk is completely different. It's gonna be good to, good to compare. Let's check the jaw and the nose now, okay?
All right.
Look up. Slowly open. Open, open, open. Different after that atlas, dude. Right? Close. Look straight. Open. Tiny bit. Just a tiny bit. Open. Close half. Open. Close. Open. Open all the way. Close. There you go. Very cool. 5, 4, 3, 2. Open. Let's click.
Yeah.
On your back here, please. There's the left side. Stuck a little on the right. So when I'm checking the septum, head down. I'm pushing right where the nasal bone stops and the septum starts. That side is fine. That's the one there. Chin down. Clonk. And let's do one of the maxillary bones. There you go. Come on up. Walk off that nose job.
Awesome. Oh yeah, it feels opened up.
And you have been steaming, yes?
Mm-hmm.
And overall, if we compare from day one, breathing is still better,
Yeah, definitely.
right? Overall, everything is better from day one,
Mhm.
but you do notice that things start to revert back slowly, right?
Yeah, I think the most I feel it is kind of when I'm sleeping. I think when I go to my side, or actually when I'm on my back, that's when it
Mhm.
starts to get kind of clogged up again.
Okay.
But yeah, throughout the day, it's a lot better.
All right, good. And what I mean is if we look at overall, right? So if we look at the neck, if we look at the jaw, the breathing, the back, overall our movements are better.
Mm-hmm.
Yes?
Yeah, not as stiff, not as tight.
And then, but what happens, because we're not, how do I say it? You notice that things start to go back to where they were, but hopefully each visit it's taking longer.
Yeah.
Things should be holding longer for you now. Yes?
Yeah, because the first time versus the most recent time, it takes longer, and I think it's also like less severe or less as bad as it was before.
Correct, and you notice it was easier to adjust today too.
Yeah.
And the idea is this, I'm gonna give everyone the example. Let's say this is the ideal relationship, and I'm just using this. This is called a functional spinal unit, bone, disc, bone, intervertebral foramen, nerve exits out, spinal cord, nucleus, and annulus or annular fiber that connects, that holds the nucleus together. So, trauma misaligns, this is Gonstead's theory, trauma misaligns the vertebrae, and it dislodges the nucleus, which is a non-compressible material, pushes back against the annular fibers, which is compressible. The weakest part of the disc is the posterior lateral aspect, so this thing pushes to the side, creates swelling, irritation, inflammation, That inflammation is what puts pressure at that nerve root, okay? It's not the bone that does it. It's the inflammation from the misalignment of the bone that causes the disc to swell. That's Gonstead's theory. So our thing is this in the Gonstead work. We want to get that repositioned back onto the nucleus. So it's a deeper, it's a different type of set. It's not a let's just twist stuff, okay? So we're setting it. Now, let's say it's been like this, and we have a declassification system, D1 through 6. But let's just say it's been like this for a couple of years in this position. We make an adjustment, set it forward. Naturally, what's it going to want to do? It's going to want to go back.
Yeah.
And in the beginning, that's why number 1, we keep on the adjustments. Number 2, we change habits. Number 3, we do a lot of walking. So it's changing all those old habits and patterns and also breaking up all that scar tissue and start to elongate, shorten ligaments. Make a sense?
Yeah.
Yeah.
So the nucleus can't move, or it could?
The nucleus does move, and that's a good question. The nucleus is non-compressible. What does that mean? It means it's pretty tough. So think of this, the way it was explained to me, think of this. Think of a big ball of yarn, you know, and you compress it down into this little nucleus. And as you do flexion, extension, think of all those yarn fibers. And as you flex and bend and twist, right, that thing is solid there and it's being held together by these annular fibers. These are concentric layers. They cross over at 22 degrees. So 22 degrees, crosses like this all the way around. And so that 22-degree crossing this way, that way, they're called concentric layers. And so that holds it in place. It also allows the flexibility, it allows a little bit of shock absorbing as well. The disc is stronger than the end plate. And we have a lot of examples, and I know a lot of other people do too, is you'll have compression fractures of the bone, but the disc is fine. So the disc, and in the Gonstead work, everything is based on the disc theory. That the adjustment is intended to reposition the vertebrae back onto the disc, on the nucleus. We get that setting corrected, then things can heal. That's the key. Okay?
Makes sense.
All right. Stand up, shake the hands. Good lesson today for everybody. Squeeze. Squeeze. You working right now? No.
All right, now, no.
Squeeze. Relax there. Squeeze. Squeeze. I think you're here for just today?
Yeah.
Go for a walk. Go walk for about an hour. Come back and just check in with me after lunchtime.
Okay.
And let's see how you're doing. And then we'll make a decision. Because you set pretty well.
Yeah, everything felt really easy.
Everything's set pretty easy. So I don't know that I need a second one today. And let's just see it. Go walk for an hour, hour and a half. Come back after lunch. We'll recheck and see.
All right.
All right, brother? Welcome back. Otherwise, I'm going to see you in 4 weeks.
Okay.
Okay?
All right.
All right, see you in a bit.
Doctor.